Good evening everyone, how are you? Hope you're doing good. Today I am going to talk about one of the important topic, that is dyslipidemia management in a diabetic patient according to AACE guidelines, American Association of Clinical Endocrinology guidelines. Let's go into the topic. As per the recommendation, a lipid panel fasting or non-fasting should be checked at the diagnosis and annually to assess cardiovascular disease and metabolic disease risk in persons with prediabetes, type 1 diabetes over the age of 40 years or type 2 diabetes patient. As per the recommendation, therapeutic lifestyle intervention remains the first choice of treatment in prediabetes, type 1 diabetes over the age of 40 years or type 2 diabetes patient with dyslipidemia. It should also include an education session with a registered dietitian or trained physician regarding the importance of weight management, daily physical activity, and regular exercise. A person with prediabetes, type 1 diabetes over the age of 40 years or type 2 diabetes with less than 2 traditional risk factors, they should be assessed with the aid of an AACE risk calculator to make a decision regarding the initiation and intensity of lipid-lowering drugs. In persons with high AACE risk, we should use a moderate intensity statin regardless of diabetes type or status. In person with very high AACE risk, for example type 2 diabetes patient with 2 or more additional traditional AACE risk factors like advancing age, hypertension, CKD stage 3A, cigarette smoking, family history of premature AACE in men less than 55 years of old, women less than 65 years of old, low HDL-C level or high non-HDL-C level, we should use a high intensity statin regardless of baseline low density lipoprotein cholesterol level. For persons at extreme risk of AACD event, for example current AACVD or target organ damage, we should use a high intensity statin plus other therapies as needed to achieve the lipid targets. So what are the treatment targets? For persons belonging to high AACVD risk categories, we should maintain LDL-C level less than 100 mg per deciliter, ApoB level less than 90 mg per deciliter, and non-HDL-C level less than 130 mg per deciliter. If the patient belonging to very high risk AACVD categories, we should maintain LDL-C level less than 70 mg per deciliter, ApoB level less than 80 mg per deciliter, and non-HDL-C level less than 100 mg per deciliter. If the patient is belonging to extreme risk of AACVD, we should maintain LDL-C level less than 55 mg per deciliter, above P level less than 70 mg per deciliter, and non-HDL-C level less than 90 mg per deciliter. As per the recommendation, statins are the initial choice of drug for hypercholesterolemia. Efficacy should be monitored every 6 to 12 weeks, and the dose of statins should be up-titrated when needed and as tolerated by the patient to achieve LDL-C levels, ApoB, and non-HDL-C goals based on the individual AACVD risk. Once lipid targets are achieved, the lipid panels can be monitored less frequently. As per the recommendation, combine ezetimibe with statin therapy when the desired lipid targets are not achieved with the maximally tolerated statin dose. If the lipid targets are not achieved with this combination, we can use PCSK9 inhibitors. Proprotein convertase subtilisin kexin type 9 lowering agent is advised along with the statin. Alternatively, the addition of bempedoic acid to the maximally tolerated statin, or consider adding icosapent ethyl, particularly in persons with triglycerides level around 135 to 499 mg per deciliter for AACVD risk reduction. As per the recommendation, intensive lifestyle modification and statin therapy remain the choice of management in patients with hypertriglyceridemia who are at high or very high risk of AACVD. The addition of fibrates or high-dose omega-3 fatty acid is advised in patients not attaining triglyceride concentrations level less than 200 mg per deciliter and HDL-C level more than 40 mg per deciliter even after the maximally tolerated statin dose. Icosapent ethyl can be considered in patients with high or very high AACVD risk. Thank you so much for your kind attention, and kindly share my lecture to your friends.